Insulin Pharmacology Viva questions. Which insulin acts fastest? Inhaled insulin, marketed as Afrezza, is currently the fastest acting insulin in clinical use. Unlike conventional insulins that are administered by subcutaneous injection, Afrezza is inhaled and absorbed directly through the lungs. Because the lungs have a very large surface area and an extensive blood supply, insulin reaches the bloodstream faster than any subcutaneous preparation. The onset is approximately 10 to 15 minutes, making it ideal for controlling postprandial glucose excursions. The peak effect occurs within 30 to 60 minutes, and the duration of action is relatively short, about 2 to 3 hours. Clinically, inhaled insulin is used as a mealtime insulin and should be avoided in patients with chronic lung diseases such as asthma or COPD. The fastest injectable insulins are the rapid-acting analogues, which are specifically designed to be injected just before meals to control postprandial glucose. The three important drugs in this group are Lispro, Aspart, and Glulisine. All three are modified forms of human insulin that are absorbed more rapidly from the subcutaneous tissue. Among them, Insulin Lispro has one of the fastest onsets, approximately 10 to 15 minutes. Insulin Aspart and Insulin Glulisine have a similarly rapid onset of about 10 to 20 minutes. Because they act quickly, patients are usually advised to take them immediately before a meal, reducing the risk of post-meal hyperglycemia. Among injectable preparations, rapid-acting analogues are the fastest-acting insulins, while inhaled insulin acts even faster overall. Which insulin is longest-acting? The answer is Degludec, which is currently the longest-acting insulin in routine clinical use, with a duration exceeding 42 hours. The reason for this prolonged action lies in its unique mechanism. After subcutaneous injection, Insulin Degludec forms multi-hexamer chains in subcutaneous tissue. These large complexes act as a depot and slowly dissociate over time, resulting in a slow, continuous release into circulation. This provides very smooth and prolonged basal insulin coverage, meaning there is a very consistent insulin concentration throughout the day and night. Another major advantage is the lower nocturnal hypoglycemia risk. Since there is no pronounced peak, patients generally experience a safer overnight glucose profile. Finally, flexible dosing. Unlike many basal insulins that require strict timing, the dose timing of Insulin Degludec can vary from day to day while still maintaining effective glucose control. Icodec, once weekly basal insulin. Icodec is an ultra-long-acting basal insulin analog, specifically designed for once weekly administration. This is a major advancement because most basal insulins require daily injections. Instead of taking insulin every day, patients receive a single injection each week, which may improve convenience, adherence, and treatment satisfaction. However, Icodec is not yet widely available in many countries, including India. Therefore, access remains limited despite its promising clinical benefits. Why is insulin not given orally? One of the most frequently asked questions in insulin pharmacology is, why can't insulin be given orally? The answer lies in the three barriers to oral insulin. The first barrier is enzymatic digestion. Insulin is a protein, and like any dietary protein, it is attacked by proteolytic enzymes such as pepsin, trypsin, and chymotrypsin. These enzymes break down insulin before it can be absorbed. The second barrier is gastric acid degradation. The stomach contains a highly acidic environment that can denature insulin, destroying its three-dimensional structure and therefore its biological activity. The third barrier is poor intestinal absorption. Insulin is a relatively large peptide molecule, so it cannot easily cross the intestinal mucosa and enter the bloodstream. Together, these three barriers, enzymatic digestion, gastric acid degradation, and poor intestinal absorption, make oral administration ineffective. Therefore, insulin must be administered parenterally, most commonly by subcutaneous injection, to ensure that an active drug reaches the circulation and produces its therapeutic effect. Why is insulin given subcutaneously? This route provides slow, predictable, and sustained absorption into the bloodstream, making it ideal for long-term glucose control. One major advantage is that it avoids GI destruction by acid and enzymes. Because insulin bypasses the gastrointestinal tract, it reaches the circulation in its active form. Another important point is that subcutaneous tissue acts as a depot for gradual release. After injection, insulin is absorbed steadily over time, allowing different formulations to produce rapid, intermediate, or prolonged effects. This route is safe and convenient for self-administration using syringes, pens, or pumps, making long-term diabetes management practical for patients. Finally, insulin enters the bloodstream more slowly than with intravenous administration. This slower entry than IV reduces the risk of rapid hypoglycemia, providing a safer and more controlled glucose-lowering effect. The key takeaway is that subcutaneous administration protects insulin from gastrointestinal destruction while providing predictable, sustained absorption, convenience, and improved safety. Compare subcutaneous versus intravenous insulin administration. Starting with subcutaneous insulin, this is the standard route used in routine diabetes management. Insulin injected into subcutaneous tissue undergoes slow depot absorption. This creates a gradual release into the bloodstream, resulting in stable blood glucose control. Because of its predictable action, it is safe for self-use and is associated with a lower hypoglycemia risk. In contrast, intravenous insulin enters the circulation immediately. This immediate entry makes it highly effective when rapid glucose reduction is required. Therefore, IV insulin is primarily used in emergencies and ICU settings, such as diabetic ketoacidosis, hyperosmolar hyperglycemic state, or critically ill patients. However, because IV insulin acts so quickly, it requires close monitoring of blood glucose and potassium levels. It also carries a higher hypoglycemia risk if not carefully supervised. While IV insulin is reserved for emergencies and critical care, the subcutaneous route remains the standard for daily diabetes management because of its safety, predictability, and convenience for long-term use.